again, the topic is making efficient use of gynaecological services in South Africa. We have no conflict of interest. What is system efficiency? Is a way of maximizing benefit of available resources and avoiding waste. The way we see the service, oncology services and delivery of oncology services, we see it in a perspective of building blocks. That is looking at the service delivery, health workforce, health information systems, access to essential medicines, financing, and leadership governance. And that will go for any service delivery that you want to implement in the medical, the health industry. And when you look at tools that you can use to try and promote efficiency, or where there's lack of efficiency, try and see what is the right thing to do. And such as the root cause analysis, which is a fishbone diagram, whereby you put all those building blocks and to try and see. This will help you to try and see where exactly is the problem in the system. And you also, there are tools, principles such as the Pareto principle, that is very famous, which actually implies that for most of the outcomes, 80% of the consequences come from the 20% of the causes. So meaning when you target a system or a service delivery, if you want to make efficiency or try and improve it, you need to target the vital few, not the whole system, because you probably will not get it right. But if you go for 20% of the vital few, you probably deliver 80% of the consequences. What is a gynecological oncology service? It's the service that offers prevention of gynecological malignancies, treatment of gynecological malignancies, provision and support of palliative services. Just to give you an idea of the South African health system, we have got the primary health system, clinic, which comprises of clinics, community health centers. And this is where most of the screening activities happen, the prevention of cancer happens. And also in the district hospitals, then going up to the regional hospitals, tertiary hospitals, and central hospitals. What is our situation in South Africa? Breast cancer and cervical cancer are still the most leading causes of deaths in our women, just like in the rest of Africa. The rest of Africa. So the prevention services that we offer are happening mainly in the primary health facilities, district level hospitals. One of the prevention cancer prevention methods is provision of HPV vaccine. Since the beginning, since 2014, we have had challenges, and even before that, we looked at our situation and said cost is going to be an issue. Shortage of staff and service points is going to be an issue, and that our population tends to be exposed early to HPV as early as 10 years. And we also have limited service points. So our interventions to that, we said we use 1 or 2 dose vaccine of cervarix. We integrated the system to the public health, to the school health program, and we targeted the young girls at age 9 and vaccinating school girls. And the program is still done at the schools, in the schools. But currently, we're facing another challenge with our HPV vaccination program. In the area, the vaccine coverage and the vaccine coverage, and we did very well until recently, where the coverage is now dropping. So this is where we are, and we're starting to see to ask ourselves, where are we going wrong? And we think something in the where are we going wrong, and then we are starting to come up with interventions. But we looking at the building blocks of our service delivery system, we are now saying maybe we should we should encourage a single dose policy, and then also encourage broader access to vaccines. That is, because in the beginning it was only the vaccination program was only involving the school girls in the public system. Now to also cover the girls in the private school system, and we must also target the HIV-infected young women, and also target the out-of-school girls. In the health information system, that is in the building blocks of our system, we're also looking at in public information campaigns and engagement, that we should talk more about this vaccine in every platform. And IT systems, employ IT systems for reminding participants of appointments and information distribution. We, at the level of prevention, again, we also have screening in the form of cytology. Currently, for the longest time, we've been using cytology, that is pap smear, to screen our women. But we also have challenges. Cytology is of poor sensitivity, but you run a risk of missing disease when you use pap smear or cytology. And our program was also a 10-year program, starting at age 30. So we were encountering a lot of problems with that. And the other issue was the poor uptake with the cytology program, long turnaround time for results, and problematic screening program as I indicated earlier on. The other problem, if you look at the graph, if you look at this is just trying to show you how ineffective this screening program is, because less than 40% of our women are participating in the screening program. What interventions did we come up with on the service delivery side? Adopt screening with high-risk HPV testing where possible. We know that it's not like South Africa is a very unequal society at every level. So it's possible in other areas, like in city areas, to deploy, but we will probably have problems in other provinces. So where possible, we advocate for high-risk HPV testing, because it seems to be better in terms of sensitivity and the fact that women can use self-sampling method for screening. So we think women will be more willing to take up this. And the other method, the other point that we think should be fixed is to equip district and provincial hospitals on colposcopies. That is what we're doing now, to treat the abnormal pap smears of cytology. Training of primary healthcare practitioners on cancer prevention, that is screening and vaccination. And we are currently now trying to adopt other strategies, treating strategies for abnormal pap smears, that is ablative therapies, because these are the methods that can be used by the middle level practitioners. Intervention at the level of leadership and governance. We encourage equitable distribution of services integration of services, e.g. integrate screening with other ongoing health services. That is, if women are coming for the vaccination program for the children, they must also be encouraged to do PAPs. And we also are trying to encourage or trying to try and push for policy change on screening and on screening. As far as the treatment services, when women now already have cancer, and this is our situation in South Africa. If you look at the ones that are shaded, when I'm standing there, can we have a highlighter? Thank you. So if you look at these ones, these ones here, this is where most of the services is happening. And you understand these are the tertiary, the provinces with tertiary hospitals. So most of the cancers are treated at this level, at the tertiary hospitals. Some provinces, we have 9 provinces, and some provinces that are offering some care, like the Free State and Libom, and the other ones do not have services at all. We've got about 3 that do not have services. So our situation is also a dire one, but I believe we have something, we can do something. So if you look at what is happening in the tertiary hospitals, like a hospital like Gauteng, where province like Gauteng, we have got 17 gynaecologists, and the chemotherapy is sufficient. Chemotherapy services, radiation facilities, radiation is also sufficient, but the waiting time is from the time a patient is discussed, it takes about 4 months. And the same for the other ones, they are roughly 3 to 6 months. But it's worse in the provinces where there are no gynaecology services. So clearly we have a problem. So what are the interventions that we are embarking on, or that we are already doing? On the leadership and governance side, we encourage decentralization of services, moving services to the secondary hospitals for the treatment of cancer. Funding of oncology fellow training. We also are engaging private funding from hospital groups, such as Netcare, Mediclinic. Support for provincial hospitals to provide services, including palliative services. On the information and research side in our building blocks, we also are encouraging continuous research efforts, data management, development of evidence-based protocols. On the service delivery, we conduct regular MDT meetings at tertiary hospitals where the services are happening. And we also encourage the strengthening of outreach and enrich programs and surgery for all operable stages of cervical cancer. So when we have an operable cancer, we operate you. Prioritize chemo and radiotherapy for those with best prognosis. So it is pointless to give chemotherapy in a patient who has, or radiotherapy patient who already has stage 4 disease. So we prioritize the ones that still have the best prognosis, because more often than not, we're loaded with many patients. There are many patients on the queue for radiotherapy, so we prioritize. And we do endoscopic surgery where possible. because it has benefits. When we think a patient can be operated today and go home tomorrow, we do it endoscopically to avoid overcrowding and because we are more often than not confronted with the situation of bed shortages. And we also encourage ongoing training and support. As a conclusion, efficient use of oncology system is essential to achieve the goals of an oncology service in a low middle income setting. Service efficiency can be achieved by improving the building blocks of systems. Despite all our challenges, women in low and middle income setting deserve quality gynaecological oncology services.